I have no financial.
There are 5 primary learning objectives for today. As this is the only physical activity module in the course, we will review some important concepts in physical activity prescriptions for patients with type 2 diabetes. First, we will apply the pre-participation screening algorithm and review the physical activity recommendations. Next, we will practice creating physical activity prescriptions. Then, we will take a deep dive into the literature to explore the effects of physical activity on weight loss and type 2 diabetes. And finally, we will conclude with a discussion exploring the minimal, threshold, and optimal levels of physical activity for achieving diabetes remission.
We begin this module with a fairly bold statement from an article entitled Treating Diabetes with Exercise from the Journal of Diabetes and Metabolism. The author states that while drugs to improve microvascular function in diabetes continue to be investigated, exercise can also provide many similar benefits on endothelial function and should remain the first prescription when treating insulin resistance in diabetes. While there are certainly many opinions on this idea, it serves as a question I'd like you to ponder for yourself as we discuss the relevant literature to see if you agree or disagree with what the literature shows. All right, so let's get started with section 1. What are the 2015 pre-participation screening guidelines for patients with diabetes? 2015 represents the current American College of Sports Medicine guidelines, and the screening algorithm requires the answer to 3 simple yes or no questions. Firstly, does the patient currently participate in regular exercise? Second, do they have cardiovascular, metabolic, or renal disease? Cardiovascular disease includes cardiac, peripheral vascular, or cerebrovascular disease. Metabolic disease importantly includes type 1 and type 2 diabetes, which we will be dealing with specifically today. And 3, does the patient have any symptoms suggestive of the above diseases? The symptoms can be at rest or with activity, include things like chest, arm, or neck pain, shortness of breath, dizziness, syncope, orthopnea, edema, palpitations, heart murmurs, to name a few. So let's look at the screening algorithm. Question 1 was if the patient currently participates in regular exercise. Let's say, for the case of an example, that the patient is not a current exerciser. Then we move to the next part of the decision tree. Now we have to know the answer to questions 2 and 3. Does the patient have known cardiovascular, metabolic, or renal disease? And now we have to know the answer to question. So let's look at the screening algorithm. Question 1 was if the patient currently participates in regular exercise. Let's say, for the case of an example, that the patient is not a current exerciser. Then we move to the next part of the decision tree. Now we have to know the answer to questions 2 and 3. Does the patient have known cardiovascular, metabolic, or renal disease? And do they have any symptoms of those diseases? Since this presentation deals specifically to treating and reversing diabetes, we will say yes to known metabolic disease. This automatically puts us in at least the middle row, where medical clearance is recommended. We will get into what medical and clearance entails in a moment, but the important thing to know is that patients with diabetes who are not already regular exercisers should undergo medical clearance. The other important thing to note on this slide is that any patient with symptoms of those 3 disease states that I just mentioned should always get medical clearance. So that was for patients who are not regular exercisers. Now, let's look at the decision tree for patients who are already exercising regularly. Similar to those people who are not regular exercisers, since we are dealing with patients who have diabetes, we can ignore the bottom row. Now, this patient has diabetes, so they have known metabolic disease. The next question is, does the patient have any symptoms? And again, symptoms always require medical clearance, as can be seen in the top row. However, in an asymptomatic patient with diabetes who is already exercising, there is no need to medically clear them for moderate intensity activity, although medical clearance is still recommended before engaging in vigorous activity for these patients. Some of you may be thinking, what the heck does medical clearance mean? The short answer is whatever you think is appropriate.
The American College of Sports Medicine specifically states that, quote, it should be the healthcare provider who decides what evaluation, if any, is appropriate before the initiation of a moderate to vigorous intensity exercise program. I recognize that this is intentionally vague, and there are no explicit mandates for what is needed to medically clear a patient. I've listed a few options to consider for patients. Obviously, a good history and physical exam are crucial. I'll provide some helpful questions for you to consider on the next slide. If there were unlimited resources, EKGs and echocardiograms would be extraordinarily helpful. Some colleges and most professional teams perform these routinely, but they are not necessary to clear someone for exercise. Lab tests may be indicated in some circumstances. Stress tests should be reserved for those with significant risk and are not recommended to be done in asymptomatic individuals at low risk of heart disease. Obviously, A cardiology referral is always an option if you're unsure of what to do. A 2021 ACSM position statement on exercise and physical activity in individuals with diabetes suggested that exercise stress testing is indicated in patients over the age of 40 with diabetes or patients older than 30 who have any of the following conditions: type 1 diabetes, or who have had type 2 diabetes for more than 10 years, hypertension, cigarette smoking, dyslipidemia, retinopathy, or nephropathy. They further recommend that anyone with cardiovascular, coronary artery, or peripheral vascular disease have a stress test. Patients with autonomic neuropathy or advanced nephropathy with renal failure should also undergo stress testing per the ACSM guidelines. Now, I don't suggest that you memorize this list. You can refer to it as needed, and when in doubt, you can always refer someone to cardiology and let them determine what tests, if any, are needed.
Well, there's a lot of information on the slide included here. This table provides a nice summary of the American Heart Association and the European Society of Cardiology recommendations for cardiovascular screening of athletes. I will not read through all these questions, but in general, they cover signs or symptoms of cardiovascular disease, premature death in the family history, or specific genetic conditions, and a focus on physical exam features seen in cardiomyopathy, aortic abnormalities, or connective tissue diseases such as Marfan's. These questions can help identify those at higher risk of sudden cardiac death and are important to inquire about. Moving on to Section 2. All right, so let's start Section 2 by looking at the National Physical Activity Recommendations, which are updated every 10 years. So these are very recent. To introduce the guidelines, I think it is helpful to see one of the primary data sources from which the guidelines were based upon. This figure shows the hazard ratios of all-cause mortality in over 650,000 adults, ages 21 to 90. The y-axis shows the hazard ratios, with anything less than 1 being protective, and the x-axis displays leisure time physical activity in met hours per week. We will discuss met hours in more detail later on. Suffice it to say that 150 minutes of moderate physical activity is about 8 met hours per week. The important take-home points from this graph are: 1, that the benefit of physical activity start with any amount of exercise, and the biggest bang for your buck actually occurs within the first 2 to 3 met hours per week of activity. 2, 70% of the benefits are accrued at 8.25 met hours per week, and there isn't an obvious, quote, best amount. And 3, there's no evidence of increased risk at the highest of physical activity accumulation, with benefits seemingly to continue to accrue, albeit with diminishing returns. Although the graph on the previous slide was for adults, we'll first look at the recommendations for children and adolescents ages 6 to 17. I'm going to skip the preschool age children, as the recommendations are essentially to encourage them to be physically active by allowing them sufficient time to play every day. For the children and adolescents ages 6 to 17, well, these are the formal recommendations. The bottom line is that kids should be running around, climbing on things, and playing outside. The guidelines recommend getting at least 60 minutes of moderate or vigorous intensity physical activity every day. Most of it should be aerobic activity, but they do encourage at least 3 days of vigorous activity, which will include activities such as running, dancing, or biking. Children and adolescents should also engage in muscle and bone strengthening activities at least 3 days per week. While this may seem like a lot at first glance, recognizing that multi-component activities such as running around and playing on a playground jungle gym could potentially be aerobic activity, muscle strengthening, and bone strengthening, these numbers are much more achievable. So moving on to adults in the 18 to 65 age range, the recommended physical activity is actually less than in children and adolescents. There's been a large emphasis recently on avoiding inactivity, and there's specific mention that some physical activity is better than none, and that adults who sit less and do any amount of moderate to vigorous intensity physical activity gain some health benefits. Similar to the 2008 guidelines, the 2018 guidelines also suggest accumulating at least 150 minutes per week of moderate intensity activity, 75 minutes of vigorous intensity activity, or some combination of both. However, they actually make this an encouraged range of 150 to 300 minutes of moderate intensity activity, or 75 to 150 minutes of vigorous activity. This is primarily to encourage people to go beyond the 150 minutes per week, as opposed to making it a goal to stop at once it's met. At this point, you may be wondering what moderate or vigorous intensity exercise actually means, and we will delve more deeply into that in a few slides. But to give you a concrete example for now, brisk walking, or what I like to think of walking as if you were late to a meeting, would be considered moderate intensity activity, as compared to jogging, which is generally seen as a vigorous intensity activity. It's also important to understand that the requirements explicitly state that muscle strengthening activities should be performed at least 2 days per week. This section often gets forgotten when we counsel people to get their 150 minutes, but this includes lifting weights, using bands, or performing any type of resistance training. The American Heart Association actually recommends 3 times per week. And lastly, the 2018 guidelines allow any duration of activity to count towards meeting the weekly number of minutes. This differs from the 2008 guidelines, which required bouts to last for at least 10 minutes to count towards your 150-minute goal.
Beyond the standard recommended guidelines, it is important to note that additional health benefits continue to accrue beyond the standard 150 to 300 minutes per week. Specifically, the new guidelines acknowledge that in order for someone to lose at least 5% of their body weight or to prevent weight gain after losing weight, physical activity of more than 300 minutes is likely necessary. This simplifies the 2008 guidelines a little, which had previously recommended 225 to 420 minutes per week for weight loss and 200 to 300 minutes of exercise per week to prevent weight regain. The new guidelines do not provide an upper limit, as individual amounts will vary.
And lastly, for adults older than 65, the guidelines are the same as for the adults in the previous slide. However, the guidelines recognize that chronic medical conditions may prevent one from achieving those target levels of activity, so these folks are encouraged to be as active as possible. Lastly, they suggest that older adults incorporate multi-component activities that include balance training to help decrease the risk of falls.
For those with complications from diabetes, such as neuropathy, nephropathy, and retinopathy, there are a few other considerations. It is important to note that peripheral neuropathy does not preclude an individual from engaging in weight-bearing activities, though they will need to pay attention to their foot care, just as any person with diabetes would. In patients with diabetic nephropathy, exercise has been shown to enhance physical functioning and quality of life. No restrictions are needed for patients with microalbuminuria either. Lastly, patients with diabetic retinopathy should avoid breath holding, overhead lifting, or any jarring head movement. To provide some more concrete recommendations, the ACSM released a 2022 consensus statement about the role of exercise and physical activity in patients with type 2 diabetes. The recommendations are largely the same as the 2018 physical activity guidelines. The notable differences are the more descriptive frequencies of the types of training, as well as encouraging more days per week of training in aerobic, resistance, flexibility, and balance domains. This table succinctly summarizes them and can be used as a reference. For those with complications from diabetes, such as neuropathy, nephropathy, and retinopathy, there are a few other considerations. It is important to note that peripheral neuropathy does not preclude an individual from engaging in weight-bearing activities, though they will need to pay attention to their foot care, just as any person with diabetes would. In patients with diabetic nephropathy, exercise has been shown to enhance physical functioning and quality of life. No restrictions are needed for patients with microalbuminuria either. Lastly, patients with diabetic retinopathy should avoid breath holding, overhead lifting, or any jarring head movement.
Probably the biggest concern for patients with diabetes who are exercising is blood sugar levels, particularly hypoglycemia. Most commonly occurs in patients using insulin. However, sulfonylureas can also cause hypoglycemia. Frequent blood glucose monitoring is needed upon physical activity initiation to avoid this. It's also recommended that patients carry additional carbohydrates with them, such as a granola bar, in case their blood sugar levels are low. While there are many different glucose management approaches, this is one previously recommended by the American College of Sports Medicine. They recommend that blood sugar be checked before and after each exercise session. The ideal range to begin exercising for most individuals is a blood sugar of 100 to 250. Blood sugar is more than 250 or 300, one should check for ketones. If ketones are present in the urine, exercise should be postponed. If no ketones are present, one can proceed with caution and make sure that they are sufficiently hydrated. An exception to this is a patient who is on insulin, in which case if their blood sugar is greater than 250, they should postpone exercise. This is because the acute effect of exercise is to augment the release of counterregulatory hormones such as catecholamines or glucagon, which in turn can cause excessive hepatic glucose production. The additional glucose being produced by the liver exceeds the blood glucose uptake in the skeletal muscle because of a lack of adequate insulin. Hence, those who require exogenous insulin need to postpone any exercise until their glucose level is better controlled. Conversely, If blood sugar is less than 100 in a person with diabetes, they recommend eating a small snack, just so that blood sugar doesn't fall too low during the exercise session. One last important point regarding insulin dosages. Exercise can lower blood sugar levels independent of insulin. So while it will take some fine-tuning of a patient's insulin dose as they begin exercising, an easy rule of thumb to remember when you're counseling one of these patients is that any rapid or short-acting insulin should be decreased by 50% prior to an exercise session to avoid becoming hypoglycemic. I'll demonstrate this for you now. Let's say we have a 45-year-old male with type 2 diabetes who has been cleared to start exercising. He wants to start exercising during lunch and is on 20 units of Lantus, a long-acting insulin daily, as well as 6 units of a short-acting insulin, Aspart, with meals. Based on this information I gave you in the previous slide, how would we adjust his dosing? Again, the recommendations are to decrease any peri-exercise short-acting insulin by 50%. This would mean that his long-acting insulin would stay at the same 20 units, and his morning and evening short-acting insulin doses would be unchanged. However, we would decrease his lunchtime dose by 50% from 6 units down to 3 units. We would still want the patient checking their blood sugar levels throughout the day, but this is a good ballpark number to start with. All right, welcome to the third section. So now that we've learned about the new guidelines and some important considerations for patients with diabetes, let's create an individualized physical activity prescription. Hopefully you're familiar with a FITT or FIT prescription. In case this is new to you, I will briefly review it. Essentially, it is a framework to prescribe customized amounts of physical activity to patients. The F stands for frequency, which would be the number of days per week one exercise is on. I is intensity, and there are many different intensity metrics one can use, which we'll review in the next slide. The first T is the amount of time they will spend doing the activity, typically the number of minutes per session. And the last T is the type, which is the mode or type of physical activity they want to do. This could be jogging, gardening, Zumba, or whatever the patient is excited about doing.
I wanted to briefly mention one other update to the FIT prescription nomenclature that you might see utilized, the FIT VP prescription. This adds 2 additional variables, V for volume and P for progression. Volume represents the total amount of exercise that an individual does by multiplying the frequency, intensity, and time together. When we're talking about aerobic exercise, we're generally going to be shooting for 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity activity over the course of a week. Volume can also be used for resistance training and is the product of the intensity or amount of weight per set, the number of repetitions, and the total number of sets in the workout. Progression is a description of how the exercise program will be advanced over time. This could mean modifying the frequency, intensity, or time. It should be done gradually. For example, it could be adding 5 minutes to a brisk walk every week or adding an additional set or repetition to a resistance training program. We are going to largely focus on using the FIT prescription in this module, though anytime we write an exercise prescription for a patient, we should also be thinking how the individual workouts fit into the bigger picture and overall volume of activity that the patient is doing, as well as when and how to appropriately progress them over time. While most of the FIT prescription is self-explanatory, the I, or intensity category, deserves some additional explanation. The guidelines we discussed focus on obtaining 150 to 300 minutes of moderate intensity physical activity or 75 to 150 minutes of vigorous intensity activity. But what does that mean? This table summarizes all of the intensity rating systems that are commonly used. The only caveat I will make before starting is that some methods will also carve out a near maximal to maximal intensity metric too. For simplicity's sake, though, I've collapsed those into the vigorous intensity category, as by definition, any near maximal or maximal exercise could still be considered vigorous too. Let's start at the top with the RPE, or rating of perceived exertion. This is a subjective scale that ranges from a 1 to 10. The individual rates how hard the activity feels to them. A 5 or 6 on this scale would be considered moderate, and a 7 or higher would be considered vigorous. Technically, a 9 or 10 is considered maximal, but again, for simplicity, I've combined vigorous and maximal intensity ratings together. As an extension of the RPE, the Borg scale operates in a similar fashion. The only difference is that it ranges from 6 to 20. It is unique in that one can generally multiply the rating that a patient gives by a factor of 10 to approximate their heart rate. This means that a rating of 6 would theoretically equate to a heart rate of 60, and a rating of 17 would be a heart rate of approximately 170. Both of these methods have remarkably good correlations with objective measures, making them easy and reliable to use. For more objective intensity measures, one can use the percent of maximum heart rate or the percent of heart rate reserve. The heart rate reserve is generally more preferred in the exercise world, but both typically rely on an estimated maximum heart rate prediction unless it can be measured directly. Estimating maximum heart rate is typically done by using the formula 220 minus the age in years. However, the accuracy of the maximum heart rate calculation can vary significantly, so one should be cautious when prescribing exercise based on it. The heart rate reserve is calculated by subtracting one's resting heart rate as opposed to their age. A percentage can then be taken from either of those numbers to come up with the percentage of maximum heart rate or the percentage of the heart rate reserve. The moderate and vigorous intensity percentages are included in the table for your reference. Obviously, if you can measure the person's maximum heart rate directly, that would be preferable to doing the calculated estimate. Next, we have METs, or metabolic equivalents. And if you get on any cardio piece of gym equipment, you can frequently view how many METs you are working at. One metabolic equivalent is defined as the amount of oxygen consumed while at rest and is equal to 3.5 milliliters of oxygen per kilogram of body weight per minute. I know that's a mouthful. If you are sitting in your chair at rest, basically you are burning the equivalent of 1 MET. To give you an idea of different activities, sleeping is approximately 0.9 METs, a slow walk or stroll is 2.3 METs, calisthenics or home exercising is typically about 3.5 METs, and biking less than 10 miles per hour is probably about 4 METs. Vigorous intensity activities would include things like jogging, which would be closer to 7 METs, or jumping rope, which would be 10 METs. It is important to recognize that METs are an absolute measure, whereas the other intensity measuring mechanisms I've included are all relative scales. This means as one gets fitter, they will be able to do more work at a given heart rate for subjective intensity. One will simply be able to exercise at higher MET ranges as they improve their cardiorespiratory fitness. The last method for measuring aerobic physical activity intensity is the talk test. This method is arguably the simplest intensity measuring system for aerobic activity. For moderate intensity activity, an individual should be able to hold a conversation with another person, but they should not be able to sing. For vigorous intensity, one should be unable to talk or sing without pausing for a breath. Resistance training intensity can be measured as a percentage of an individual's 1 repetition maximum. 70% or more would be considered vigorous. However, a 1 repetition maximum is often not known, so another method that can be used is the repetition or reps in reserve. A moderate intensity set would be one where an individual terminates a set knowing that they probably could have done an additional 4 to 6 repetitions with good form. Vigorous would be a set where 3 or fewer repetitions could have been performed with good form. Moderate intensity is generally considered lifting 50 to 69% of an individual's 1 repetition maximum. Vigorous intensity would be considered anything greater than 70% or more of an individual's 1 repetition maximum. All of these intensity systems have their advantages and disadvantages. In general, I recommend people choose 1 to 2 and become very familiar with how to prescribe them. I personally like the rating of perceived exertion and the talk test, particularly when I'm working with someone who is just starting an exercise program.
So here's a nice table from the CDC that provides concrete examples for what activities are considered moderate or vigorous intensity. Although prescribing an appropriate intensity is arguably one of the most nuanced aspects. So here's a nice table from the CDC that provides concrete examples for what activities are considered moderate or vigorous intensity. Although prescribing an appropriate intensity is arguably one of the most nuanced aspects of the FIT prescription, I wanted to make a few comments about the final T, type. In addition to matching the type of exercise to what the patient's preferences are, there are a few other important considerations. For example, non-weight bearing activities may be more appropriate to start out with for patients who are obese. This decreases the amount of impact and force sustained by their joints and may help them avoid having pain during activity. However, in general, it's good to have a combination of weight-bearing and non-weight-bearing activities, as weight-bearing activities are important for bone strengthening and are particularly important for postmenopausal women and older adults. I put a star by resistance training as it is generally considered anaerobic and could be considered either weight-bearing or partial weight-bearing depending on the exercise chosen. For example, many pieces of gym equipment allow you to sit down and perform the movement. Heavy resistance training in particular may reverse or prevent further loss of skeletal muscle due to disuse and aging. Increasing muscle mass may further increase glucose uptake as well. Lastly, high-intensity interval training, or HIIT for short, can be performed with any mode of exercise. It involves periods of all or nearly all-out effort interspersed with extended periods of recovery. It can be very beneficial, particularly for cardiorespiratory fitness when prescribed appropriately. Now, it's your chance to practice writing a fit prescription. In this example, we have a 62-year-old female with type 2 diabetes who has been cleared to exercise. She wants to walk every weekday with her friend and accrue 150 minutes per week of physical activity. What would her fit prescription look like? So since the patient wanted to walk every day, the frequency would equal 5 at a moderate intensity, giving us a rating of perceived exertion of 5 to 6, and wanted to achieve 150 minutes, she would need to exercise for 30 minutes during each of the 5 sessions. She expressed wanting her type of activity to be walking with her friend, so her fit prescription would look like this. So a question I frequently get asked by patients is, which modality is the best? The short answer is the one that the patient will do. In terms of reversing diabetes, though, let's see what the literature says. The effect of different intensities of aerobic activity alone on glucose control has been looked at in patients with type 2 diabetes. In fact, a 2017 meta-analysis was conducted that was able to provide a dose-response estimate. It included 27 randomized controlled trials in adults, of which 2/3 of the studies utilized vigorous and 1/3 of the studies utilized moderate intensity physical activity. The median exercise session lasted 50 minutes and occurred 3 times a week. This resulted in an average weekly exercise time of 40 to 300 minutes. The average study length was a little over 4 months. The authors found a median drop in hemoglobin A1C of 0.69 percentage points, which was statistically significant. They were also able to estimate that for every additional week of physical activity performed led to a further absolute decrease in hemoglobin A1C, an additional 0.009 to 0.043 percentage points. Now, one important note about this slide and future slides where I discuss hemoglobin A1C changes, the percent A1C changes are all absolute changes in hemoglobin A1C measures, not relative percent changes. So a change of 0.69% as indicated on this slide would mean a change from a hemoglobin A1C of 7.69% down to an A1C of 7.0%. But what about the effect of resistance training alone or in combination with aerobic activity? This question was analyzed in a study published in the Annals of Internal Medicine in 2007. It included 251 adults ages 39 to 70 with type 2 diabetes. They had participants exercise 3 times per week for 22 weeks, doing either mostly moderate aerobic activity, purely resistance training, or both aerobic and resistance training combined. After 6 months, they compared to the control group. Those in the aerobic training decreased their A1C by 0.51 percentage points. Those in the resistance training group decreased their A1C by 0.38 percentage points. However, the group that did both the aerobic and the resistance training decreased their A1C nearly a whole percentage point. This question was further analyzed in a 2010 randomized controlled trial published in JAMA. The authors recruited 262 sedentary adults with type 2 diabetes and an average A1C of 7.7%. They had one group perform 150 minutes per week of aerobic activity alone, another group performed 3 resistance training sessions per week, and the third group did a combination of the two, performing 2 resistance training sessions plus aerobic activity. Compared to the control group at 9 months, the researchers found that aerobic training group decreased their A1C by 0.24 percentage points, the resistance training group by 0.16, and the combined group by 0.34 percentage points. It is important to note that in the study on the previous slide, the combined group essentially did the entire aerobic and resistance training interventions, whereas in this study, the combined group performed a portion of each aerobic and resistance study arm. This likely explains the difference in the absolute A1C reductions achieved in the combined group as compared to the aerobic or resistance training alone group in each of the studies. One last look at this question of what modalities are best for diabetes reversal. In a 2018 meta-analysis that included 37 randomized controlled trials and examined supervised aerobic and resistance training, although there were no significant differences in weight loss between the interventions, they found a 0.30 percentage point reduction in hemoglobin A1C in aerobic exercise or resistance training alone as compared to no exercise. However, they found a 0.53 A1C percent point reduction in the combined exercises as compared to no exercise. Hopefully, the last few studies have driven home the point that any type of physical activity can help reverse diabetes, but that a combination may be preferred. This is not surprisingly reflected by American College of Sports Medicine's and the American Diabetes Association's statement on exercise and type 2 diabetes that states, quote, "A combination of aerobic and resistance training may be more effective for blood glucose management than either type of exercise alone." But what about high-intensity interval training, or HIIT training for short?
HIIT has become quite popular in the last 5 to 10 years. It is a very time-efficient type of training that is generally considered to be superior to lower-intensity training, though we will explore this data in patients with type 2 diabetes over the next few slides. The HIIT sessions are typically structured around specific work and rest intervals. So an individual will work at 75 to 90% of their maximum heart rate for anywhere between 10 seconds and 4 minutes, which would then be followed by an active or passive recovery for 12 seconds to 6 minutes. These are very physically demanding, vigorous intensity workouts, and not something any person who is new to exercise should start out with. If you recall from the pre-participation algorithm, that it is recommended that patients with type 2 diabetes receive medical clearance before beginning a vigorous intensity exercise program, even if they are currently exercising. So you want to be sure to do that ahead of time. I realize this is a busy table, though it succinctly summarizes all of the meta-analyses findings in patients with type 2 diabetes engaging in a high-intensity interval program. The first study in the table, published in 2016, included 8 randomized controlled trials, 4 of which were HIIT. They compared these to low-intensity exercise protocols and found that higher intensity exercise decreased hemoglobin A1C by 0.22%, more than the lower intensity exercise prescriptions. The 2017 meta-analysis by Grace and colleagues was the largest one, as it included 27 prospective or randomized controlled trials. Importantly, they compared HIIT to sedentary controls. This explains why they found a 0.71% absolute decrease in hemoglobin A1C. This magnitude is similar to what is seen when comparing an aerobic exercise program in randomized controlled trials to sedentary activity, suggesting that HIIT is at least equivalent, possibly slightly better than standard aerobic exercise in decreasing hemoglobin A1C. To contrast the previous studies, a 2018 meta-analysis in patients with prediabetes or type 2 diabetes found no significant difference in A1C or any other typical cardiometabolic risk factor. They did find a significant increase in functional capacity as measured by VO2 max in the HIIT interventions, though. And then lastly, the most recent meta-analysis done in subjects with type 2 diabetes compared HIIT to moderate intensity exercise programs. It included 13 randomized controlled trials and found a 0.37% absolute reduction in hemoglobin A1C, along with significantly improved VO2 max and decreased body weight in the HIIT interventions as compared to moderate intensity exercise programs. And based on all these meta-analyses I just showed you, I think the most recent 2018 trial by Liu and colleagues best reflects the role HIIT can play in patients with type 2 diabetes. In addition to only including randomized controlled trials, it importantly compared HIIT to moderate intensity exercise, which I would consider the true standard of care. It still found an additional absolute A1C decrease of 0.37 percentage points, more than the moderate intensity activity alone, which I think is important. So the take-home message is that HIIT can probably provide additional cardiorespiratory fitness benefits beyond continuous moderate intensity training, and that it may improve hemoglobin A1C more in patients with type 2 diabetes. The jury is probably still out on prediabetes, though there is reason to believe it may help them as well. The bigger issue is making sure that patients with type 2 diabetes are medically cleared and safe to proceed with engaging in a HIIT program. Section 4. We will now look at the benefits and limitations of physical activity on weight loss and type 2 diabetes. First, we will start with weight loss.
According to data from a study published in the New England Journal of Medicine using the Nurses' Health Study database, in over 84,000 women, BMI was found to be the single most important risk factor for type 2 diabetes development. As you can see, the relative risk increases exponentially as one goes from a BMI of less than 23 to being overweight to being obese, with a relative risk being 20.1. So why do we care about weight? Well, in a 2015 review on exercise training and insulin resistance, the authors suggested that weight loss was the primary driver of improved insulin sensitivity. However, they concluded that exercise-induced weight loss improved insulin sensitivity more than caloric restriction weight loss alone. This was felt to be due to the additional benefits that exercise offered, specifically increasing mitochondrial oxidative capacity, suppressing unnecessary gluconeogenesis, and improving body composition. While these concepts are important to consider, what happens in actual trials is more relevant. So let's look at a few. We will start with the look-ahead trial, which we will go into great detail in a few slides. Essentially, this study looked specifically at weight loss and improvements in overweight and obese individuals with type 2 diabetes. They found that weight loss predicted the likelihood of decreasing hemoglobin A1C by at least 0.5%, and the more the better. People who lost at least 15% of their body weight were almost 3 times more likely to reduce their A1C by at least 0.5% than participants who only lost 5 to 10% of their body weight. This notion was reinforced by the Why Wait trial. This was a 12-week intensive program in patients with obesity and type 2 diabetes. It included medication management, dietary advice, behavioral support, and physical activity, including both moderate intensity, aerobic, and strength training that progressed from 20 minutes a day, 4 times a week, to 60 minutes, 6 days a week. Remember, this was a 3-month intervention, and at 1-year follow-up, 88 subjects who completed the trial, 21.6% of participants had an A1C of less than 6.5% at the end of 1 year. Even more impressively, 4.5% had achieved partial or complete remission of their diabetes. Partial remission was defined as an A1C of less than 6.5%, and complete remission was having an A1C less than 5.7% and not being on any diabetic medications. The authors then took these results one step further and said, what were the primary predictors of the patients who were able to achieve partial or complete remission? It turns out that having diabetes for less than 5 years, having a baseline hemoglobin A1C of less than 8%, being on 2 or fewer medications, and losing more than 7% of body weight after the 3-month intervention were the most important factors. While your patients cannot necessarily control their baseline A1Cs, encouraging a greater than 7% weight loss in the first 3 months seems to be an important metric to hit. All right, so we spent a significant amount of time discussing the importance of body weight and its association with diabetes, but can exercise actually help patients lose weight? Let's start by looking at 2 meta-analyses. The 2011 meta-analyses on the left here that looked at the effect of isolated aerobic exercise on weight loss. It included 14 randomized controlled trials with overweight and obese adults. At 6 months, patients were able to lose 1.6 kilograms of body weight on average, and this only increased to 1.7 kilograms at 1 year. Based on those results, the authors concluded that, quote, isolated aerobic exercise is not an effective weight loss therapy in these patients, but may still be an effective weight loss therapy in conjunction with diets. Now, in a second meta-analysis looking at this that was published in 2018, the authors looked at diet plus exercise. It included 11 RCTs of overweight or obese women compared to the controls. They found a mean difference of additional weight loss of 3.4 kilograms versus 6.55 kilograms in the exercise and diet groups, respectively. Combining diet and exercise yielded an additional 1.22 kilograms of weight loss as compared to the diet alone interventions. This is summarized in red at the bottom of the slide, where one can see that exercise can aid in weight loss, but diet seems to play a much bigger role. Clearly, diet is powerful, but before you dismiss exercise, it is important to recognize that this study looks specifically at body weight. A properly designed exercise program can actually increase muscle mass, thus offsetting some of the quote-unquote weight loss that an individual is having. Percent body fat would be a much better measure, though this isn't as frequently reported in studies as one would like. For example, if the exercise group had lost 6.55 kilograms of fat, but then gained 3 kilograms of muscle, they would actually be much healthier metabolically than a diet group that lost a significant amount of muscle mass in the process. It's impossible to know what happened in this particular case, but this is an important consideration to have when looking at weight loss, particularly if studies include a resistance training component. Looking at these numbers, though, one might conclude that maybe exercise isn't the best thing for weight loss. All right, so we spent a significant amount of time discussing the importance of body weight and its association with diabetes, but can exercise actually help patients lose weight? Let's start by looking at 2 meta-analyses. The 2011 meta-analyses on the left here that looked at the effect of isolated aerobic exercise on weight loss. It included 14 randomized controlled trials with overweight and obese adults. At 6 months, patients were able to lose 1.6 kilograms of body weight on average, and this only increased to 1.7 kilograms at 1 year. Based on those results, the authors concluded that, quote, isolated aerobic exercise is not an effective weight loss therapy in these patients, but may still be an effective weight loss therapy in conjunction with diets. Now, in a second meta-analysis looking at this that was published in 2018, the authors looked at diet plus exercise. It included 11 RCTs of overweight or obese women compared to the controls. They found a mean difference of additional weight loss of 3.4 kilograms versus 6.55 kilograms in the exercise and diet groups, respectively. Combining diet and exercise yielded an additional 1.22 kilograms of weight loss as compared to the diet alone interventions. This is summarized in red at the bottom of the slide, where one can see that exercise can aid in weight loss, but diet seems to play a much bigger role. Clearly, diet is powerful, but before you dismiss exercise, it is important to recognize that this study looks specifically at body weight. A properly designed exercise program could actually increase muscle mass, thus offsetting some of the quote-unquote weight loss that an individual is having. Percent body fat would be a much better measure, though this isn't as frequently reported in studies as one would like. For example, if the exercise group had lost 6.55 kilograms of fat, but then gained 3 kilograms of muscle, they would actually be much healthier metabolically than a diet group that lost a significant amount of muscle mass in the process. It's impossible to know what happened in this particular case, but this is an important consideration to have when looking at weight loss, particularly if studies include a resistance training component. Looking at these numbers, though, one might conclude that maybe exercise isn't the best thing for weight loss. All right, so we spent a significant amount of time discussing the importance of body weight and its association with diabetes. But, like any drug, maybe it's an ineffective dose of physical activity. The proof of concept of adequate physical activity dosing is eloquently illustrated in this randomized controlled trial published in 2018. I know this is a busy slide, but I think it's important to see the numbers to get a sense for a possible threshold effect of energy compensation that might exist. So this trial was done in 36 overweight or obese adults. The researchers had both groups exercise 5 times a week for 12 weeks. However, one of the groups, they had them burn 300 calories per session, resulting in roughly 1,500 calories burned for the entire week. The second group burned twice as many calories by burning 600 calories per session, or approximately 3,000 calories per week. The researchers then looked at how much the participants compensated in their diets as compared to the number of calories that they had burned exercising. They found in both groups that the participants essentially compensated for 1,000 calories of additional food eaten across the week. This is important to appreciate as one group only burned 1,500 calories total, with 943 of them being compensated for. Meanwhile, the group that burned 3,000 calories per week only compensated 64 calories more than the 1,500 calorie group. As one would expect, the weight loss was substantially higher in the 3,000 calorie group than the 1,500 calorie group. They lost 2.6 kilograms of fat mass, whereas the 1,500 calorie group only burned 0.8 kilograms of fat. Interestingly, the weight loss was only significant in the 3,000 calories per week group and not the 1,500 calorie per week group. This led the authors to conclude that exercise energy expenditure of 3,000 calories per week is great enough to exceed compensatory responses and reduce fat mass. So like many things in medicine, the dose matters. Physical activity and weight loss are no different. One can lose weight with physical activity, but requires a substantial amount of time and energy. To give you an idea of how challenging it would be to burn 600 calories in a session, one would need to walk or jog roughly 6 miles. Participants in that study that I just showed you did the equivalent of that 5 days a week. So as you can see on this slide, the American College of Sports Medicine and American Diabetes Association stated that an hour per day of moderate intensity physical activity leads to roughly as much fat loss as an equivalent caloric restriction, with resultant greater insulin action. The trial I just showed you supports this. How one loses weight does matter, and if patients with diabetes can exercise, it is a preferable way to help create a caloric deficit in addition to dietary changes. So now that we've discussed the relationship between physical activity and weight loss, we can move on to the more relevant question for this module, the effect that physical activity has on hemoglobin A1C. First, let's start with a brief reminder of the physiologic effects that exercise has on insulin sensitivity. One of the most important adaptations is the improved mitochondrial function and increased GLUT4 expression it leads to. Other than insulin, GLUT4 is the major other pathway that cells can uptake glucose from the bloodstream. Additional beneficial effects that are mediated by physical activity include increased muscle mass, improved VO2 max, mitochondrial biogenesis, and increased insulin sensitivity. Just to reiterate what was discussed previously, losing weight by simply eating less does not provide these same metabolic adaptations that are elicited by muscle. However, we know that weight loss is one of the primary drivers of diabetes and insulin resistance, and it is much easier to create a caloric deficit through diet than through a comparable amount of physical activity. Think about it. What's easier, not getting a ground latte at Starbucks or walking 2 miles? Therefore, the combination of both of these approaches is ideal to maximize weight loss and leverage the advantageous metabolic adaptations that are seen with exercise.
Acutely, exercise can improve postprandial glucose levels by attenuating glucose spikes. Any exercise intensity can work, other than HIIT, which can actually cause a transient increase in glucose levels. In general, though, the longer the activity, the better, as there's more time for glucose to be removed from the bloodstream and taken up by skeletal muscle. In as little as 2 weeks, exercise can significantly decrease pancreatic fat and improve beta cell function. Definitely important for putting type 2 diabetes into remission. Moving from the acute effects exercise has onto the chronic impacts, the take-home point is that overall it improves insulin sensitivity. One of the important adaptations is the improved mitochondrial function and increased GLUT4 expression it leads to. Other than insulin, GLUT4 is the major other pathway that cells can uptake glucose from the bloodstream. Additional effects that are mediated by physical activity include increased muscle mass, improved VO2 max, mitochondrial biogenesis, and increased insulin sensitivity. One of the primary reasons that A1C reductions occur is from the improved insulin sensitivity that regular exercising leads to. The improved insulin sensitivity can provide substantial benefits lasting for more than 72 hours after the last bout of exercise. We know that creating a calorie deficit and losing weight is one of the primary ways diabetes remission can be achieved. It is also much easier to create a caloric deficit through dietary changes than through a comparable amount of physical activity. Think about it. What's easier, not getting a grande latte at Starbucks or walking 2 miles? However, exercise has important effects on glucose metabolism beyond what dietary weight loss can provide. This isn't to say that both aren't important. Rather, it highlights the value that each approach can offer. Dietary changes can induce greater weight loss, though physical activity can help improve physiological processes while contributing some to weight loss as well. Combining both approaches can maximize weight loss and the chances of achieving prediabetes or type 2 diabetes remission.
All right, so now that we've briefly reviewed some of the basic physiology, what sort of impact would one expect to see on hemoglobin A1C clinically? This 2005 prospective study followed 179 patients with type 2 diabetes for 2 years and categorized patients into groups of physical activity using MET hours per week. If you need a METs refresher, go back to the first section where we discussed intensities. Again, for reference, 10 MET hours per week is roughly equivalent to doing 180 minutes of moderate intensity activity per week. And those doing 10 or few MET hours per week, which is, I should point out, more than the physical activity guidelines recommend, there was no significant change in hemoglobin A1C or any of the other parameters measured. Participants doing more than 10 MET hours per week saw an A1C drop of 0.4 percentage points, and those doing more than 20 MET hours per week, which would be more than 60 minutes, 6 days a week, decreased their A1C by a whole percentage point, in addition to the numerous other health benefits. Remember, these numbers are from physical activity alone and do not include specific dietary changes too. This suggests that there may be a dose-response relationship beyond a certain physical activity threshold. So in this 2011 meta-analysis published in JAMA, they compared supervised physical activity with physical activity advice alone in studies lasting at least 12 weeks in diabetics. Note that they included trials of aerobic and or resistance training with or without dietary co-interventions, which makes the effect of the exercise intervention on hemoglobin A1C a little more difficult to interpret since it's confounded by any dietary interventions that occurred simultaneously. For example, is the hemoglobin A1C going down because they're eating a healthier diet or because of the new exercise program, or both? And what percent does each contribute to that? For those who are interested in teasing this out, the forest plot summarizing all of these studies is on the next slide, including the individual weights assigned to the studies. Regarding the primary A1C reductions reported, it is interesting to note that the aerobic activity had a 0.73% A1C reduction, but that combined aerobic and resistance training protocols fared worse than either intervention alone. While many things could explain this, two of the most important factors I'd be interested in would be the baseline demographics of the study population, as well as the dose of the various protocols. One can imagine that more impressive A1C drops could be seen with patients who start out at a hemoglobin A1C of 13%, for example, than with a hemoglobin A1C of 6.5%. Regarding the dosing question, the authors address it quite nicely by further stratifying the results of their interventions that achieved more than 150 minutes per week. After seeing the energy compensation data, it's not surprising that the effect of exercising more than 150 minutes per week led to hemoglobin A1C reductions closer to 0.90 percentage points, as compared to the 0.36 seen when less than 150 minutes per week was performed. Obviously, when you take the averages of these numbers, you end up in the ranges listed above. Again, this just reinforces the importance of getting a sufficient physical activity dose to obtain the best results. And one final point I'll make regarding these data. So in this study, giving physical activity advice alone without making any dietary changes did not result in any A1C reduction. Remember, the A1C reductions reported are for studies that had structured exercise interventions, meaning that participants showed up to a gym or underwent supervised exercise sessions as opposed to just encouraging people to be active. This underscores the importance of making sure that patients have the ability, means, motivation, and resources available to actually engage in exercise on their own. If not, figuring out how we can help them or referring them to someone who can, critical. It doesn't matter how effective a medicine is if no one is willing to take it.
And as promised, for those of you who really wanted to dig into the individual studies, this slide includes a forest plot of all the results from the just discussed meta-analysis, as well as the A1C reductions reported in the previous slide.
So what is the takeaway from the 2011 meta-analysis? First, all forms of exercise are good, particularly aerobic. 2, increased durations of physical activity, specifically greater than 150 minutes per week, was more effective at reducing A1C. 3, although I didn't go into detail discussing this, the study authors did not find any additional A1C benefit from high-intensity exercise on A1C reduction. And lastly, but very importantly, merely telling a patient to be active is insufficient. Additional support mechanisms and resources are needed to achieve the levels of physical activity that can help reverse diabetes. Interestingly, 2 years later, the same group performed a similar meta-analysis looking at different exercise volumes, specifically the number of sessions per week and hemoglobin A1C reductions, to see if there was a dose response. It included 26 randomized controlled trials in patients with diabetes that lasted at least 12 weeks. The next slide will show the study reductions graphically, but similar to the 2011 meta-analysis, they found hemoglobin A1C reductions of 0.70% in aerobic training studies and 0.62% in resistance training studies, and 0.47% in studies that combined both aerobic and resistance training. The authors recognized the heterogeneity in the previous study and how volume could significantly affect the A1C changes seen. By reviewing the individual studies, they actually estimated the different baseline hemoglobin A1C levels and frequency of exercise explained over half of the variability between the different study results. So let's take a look at what their results look like graphically. So this figure summarizes the aerobic findings of their meta-analysis. The y-axis shows hemoglobin A1C changes with a dashed line at 0, and the x-axis shows the number of aerobic sessions per week. Remember, the reported hemoglobin A1C reduction for aerobic activity was 0.70%. As you can see, though, the range of results vary from some studies showing a worsening of hemoglobin A1C to one study with nearly a 3 percentage point drop in A1C. Aggregating all these studies yielded this downsloping regression line, which would suggest that an increased number of aerobic exercise sessions appears to decrease A1C in a dose-response fashion. These data also highlight the heterogeneity that can exist between studies. And although the study addresses exercise volume using sessions per week, as we explored the importance of the physical activity dose previously, sessions of 30 minutes versus 60 minutes or 90 minutes could have vastly different results. Trials that are barely meeting the compensatory threshold will be less likely to result in a significant weight loss and may yield a lower reduction in hemoglobin A1C than one might expect. The take-home point here is that all of these seemingly minor study details can have profound effects on the results that are reported. All right, so we're in the home stretch. This is going to be the last and one of the most important studies that we discuss. The look-ahead trial, again, was one of the largest intensive lifestyle intervention randomized controlled trials in patients with diabetes. They randomized 5,145 overweight adults ages 45 to 74 with A1Cs of less than or equal to 11 into two groups. The first one received diabetes support and education, and the other received an intensive lifestyle intervention, which consisted of a reduced calorie diet using meal replacements initially before gradually replacing those with fruits and vegetables. Weight loss was the major outcome, with the goal of having at least 10% body weight lost and 175 minutes of moderate intensity physical activity accumulated each week. To help ensure that participants achieve the weight loss goal, orlistat was prescribed to subjects who did not lose at least 5% of their body weight by 6 months. At the end of the year, the intensive lifestyle intervention group lost 8.6% of their body weight on average, compared to 0.7% in the education and support group. Participants were exercising 137 minutes per week and experienced an A1C reduction from 7.3 to 6.6%. Interestingly, the author stated that greater self-reported physical activity was the strongest correlate of weight loss. What this means graphically is that people who were in the highest quartile of physical activity exercised for an average of 287 minutes per week and lost 11.9% of their body weight. As this figure shows, there appeared to be a dose-response relationship between physical activity duration and weight loss. Although we've already seen that obesity and diabetes are closely associated with one another, what did the weight loss in the study mean for the participants' blood glucose control? And as you can see, the partial or complete remission rates for diabetes was 11.5% after the 1-year intervention. This subsequently dropped to 7.3% at the 4-year follow-up, whereas the standard diabetes education group saw a non-significant 2% remission rate at year 1, which dropped to 1.5% at the 4-year follow-up. Remission in the study was defined as a transition from meeting diabetes criteria to a pre-diabetes or non-diabetic level of glycemia without being on any anti-hyperglycemic medications. All right, so we are done going through all of the studies. Let's briefly summarize all of the data I showed you and the meta-analyses that I threw at you. Again, I know there's a lot of information in this table, but we'll walk through things slowly here. Essentially, this table is a summary of all of the most recent meta-analyses that you have already seen involving a physical activity intervention only. It does not include the last 2 meta-analyses that I showed you, since those included dietary interventions as well, making them more difficult to interpret the effect of physical activity alone. It also includes the look-ahead trial at the bottom of the slide that we just discussed to give you a sense for what A1C reductions were needed to achieve approximately a 12% diabetes remission rate. In brief, the study by Grace et al. Suggested that aerobic activity ranging from 40 to 300 minutes could lead to an A1C reduction of 0.69 percentage points. The Bay et al. Study looked at resistance training in isolation or in combination with exercise and found a nearly additive decrease in A1C of 0.53% in the combined studies as compared to a 0.30% reduction in either aerobic or resistance training alone. The last 2 meta-analyses were the high-intensity interval studies we discussed, with the first finding no significant difference when looking at diabetics and pre-diabetics, and the second revealing an additional 0.37% A1C reduction in diabetics who engage in high-intensity interval training as compared to just moderate intensity activity alone. And then lastly, the year-long look-ahead trial, which combined physical activity with caloric restriction, found a 0.70% A1C reduction after a year. While this table is fairly consolidated, I'll see if I can make the take-home message a bit clearer by combining all of these effects together in an even simpler table. So here's one table to rule them all. You may want to screenshot this or take a picture using your phone for reference. It is the most succinct summary of all the results from the aforementioned meta-analyses and trials using physical activity interventions without dietary changes, and includes the expected range of hemoglobin A1C reductions one might expect to see. Obviously, this is arguably oversimplified and cannot account for the baseline differences in participants or populations, and is subject to the different physical activity dosing challenges I mentioned previously. But in general, by simply adding a realistic aerobic exercise program to a patient with diabetes who is not at goal, one could expect to see a 0.30 to 0.70% A1C reduction, holding everything else equal. Alternatively, by adding solely a resistance training program, one might expect A1C reduction of 0.30 to 0.62%. Splitting the physical activity time between aerobic and resistance training would yield an A1C reduction of roughly 0.5%. And lastly, for patients who are fit enough and want to perform high-intensity interval training, it is possible that up to an additional 0.37% reduction in A1C might be achievable beyond what one would expect to see with aerobic exercise alone.
Section 5.
Our last objective will cover what to do with all this information. What sort of physical activity advice should we be giving patients? We will start with the minimal physical activity dose, as this is fairly straightforward. Per the ACSM and ADA, there is no minimal dose of physical activity. Any amount of physical activity you can get patients to engage in is better than none. Next, threshold dose for diabetes treatment and reversal. In one of the landmark lifestyle medicine studies published in the New England Journal of Medicine, it showed a 58% reduction in prediabetes progressing to overt diabetes as compared to a 31% reduction in patients taking metformin. Subjects performed at least 150 minutes of moderate intensity physical activity per week. This is consistent with the ACSM and ADA position statements that encourage all adults to achieve those metrics. The majority of the literature published looking at intensive lifestyle interventions designed to treat and reverse diabetes prescribe at least this much physical activity in addition to diet and other interventions. Without question, accumulating 150 minutes per week of moderate intensity physical activity and engaging in at least 2 strength training sessions per week should be part of a comprehensive diabetes treatment plan, in addition to being a guideline that all adults should look to meet.
A relevant side note regarding the minimal amount of physical activity needed is that sedentary behavior by itself is problematic. Physical inactivity increases the odds of developing type 2 diabetes by nearly 2-fold. This study of more than 27,000 adults found that each hour of daily sitting was associated with a 4% increased odds of developing type 2 diabetes. Similar data were reported in a separate study of 291 adults with type 2 diabetes, which found that each additional hour of sedentary time was associated with an increased metabolic risk independent of the amount of time spent performing moderate to vigorous intensity physical activity. Now, 2 interesting questions arise from these observations. 1, does performing physical activity throughout the day aid in blood sugar control? And 2, is breaking up the physical activity better than performing it in a single continuous session or not? Not surprisingly, the answer to the first question is yes. Small bouts of physical activity throughout the day can help attenuate postprandial glucose. Physiologically, this makes sense, as exercising causes skeletal muscles to uptake glucose from the blood to use for energy. A 2020 meta-analysis of 37 studies confirmed that compared to sitting all day, breaking up prolonged sitting with bouts of physical activity throughout the day moderately attenuated postprandial glucose, insulin, and triglyceride levels. This effect was more pronounced in individuals with higher BMIs. However, the more interesting second question is whether breaking up activity into small bouts is better than doing it all at once or not. In theory, it might be helpful to dose physical activity throughout the day. This meta-analysis I just referenced also looked at this, and they found a very slight statistically significant advantage for physical activity breaks over continuous exercise for attenuating postprandial glucose with a p-value of 0.03 and a confidence interval that almost crossed 0. A 2013 study in 11 young adults with prediabetes compared sedentary behavior to 1 hour of continuous moderate intensity exercise versus 5-minute intervals of moderate intensity exercise each hour over 12 hours, and found that the 5-minute periods of exercise attenuated glucose excursions, leading to lower blood glucose levels over a third of the day, as well as a 15% reduction in insulin area under the curve measures as compared to the continuous 1-hour session. This suggests that there could be a metabolic advantage to doing this, though it is arguably a bit impractical to do 5-minute exercise sessions 12 times per day. A better gauge of how this might work in the real world was a crossover study done in a free living environment. 30 participants were split into 3 groups that walked for either 20, 40, or 60 minutes. Each participant served as their own control and walked both continuously and in divided sessions after breakfast, lunch, and dinner for their assigned exercise time. They found that continuous walking was more effective than breaks from sitting in lowering daily hyperglycemia, but that both conditions lowered breakfast postprandial glucose levels. These free living environments results contrasted with the controlled laboratory studies that typically showed improved hyperglycemia when taking breaks throughout the day. So in summary, the jury is still out on the second question. Exercise breaks may offer some benefit, though it's unclear how beneficial. The more important thing is finding an exercise program that patients can stick to, whether it's short or continuous bouts of exercise.
Now, a much harder question: how much physical activity is optimal for diabetes reversal? The short answer is we don't know. Clearly, there are beneficial metabolic adaptations that occur with aerobic and resistance training. Although some may argue that the combined groups didn't reduce A1C as much, the only study that added the aerobic activity to the resistance training activity, as opposed to splitting them in half when they combined them together, showed a nearly additive effect of each modality. I think without question, an optimal physical activity dose combines both aerobic and resistance training in addition to diet. The next question is, what are the optimal doses of aerobic activity and resistance training? Well, with aerobic activity, the preponderance of evidence would suggest that more is better. The ACSM had previously recommended accumulating 225 to 420 minutes per week to promote clinically significant weight loss, which was recently updated to just greater than 300 minutes per week. Weight loss would certainly aid in decreasing A1C levels. I think this is a reasonable range to be considered optimal, at least from an efficiency standpoint. But honestly, additional health benefits and A1C reductions can almost certainly be gained with higher levels of physical activity beyond 300 or even the previous 420 minutes. 420 minutes of physical activity per week equates to 60 minutes every day, which is no small feat. For people who want to optimize their physical activity further, rather than increasing the total time beyond that, I think it probably makes more sense to encourage them to increase the intensity and shorten the duration. High-intensity interval training is a perfect option for these individuals and probably does provide some additional benefit in addition to being much more time efficient. In an optimal program, I think HIIT should be included, if for no other reason than to provide some variety, improve fitness, and expose someone to a different training stimulus. Regarding the optimal dose of resistance training, recommendations suggest training at least twice weekly. However, there's compelling evidence that an optimal dose may be 3 times per week on non-consecutive days. All major muscle groups should be worked using 8 to 10 mostly compound movements, such as a squat, bench press, or push-up, pull-up, or deadlift. Individuals should also move from lighter weight ranges to the 75 to 80% of their 1 repetition maximum, as well as aim to increase the total number of sets that they perform from 1 to 3 or 4 sets per exercise. These variables are a bit more complex to manipulate, unless one is particularly interested in the more granular resistance training prescription. It may be more appropriate for healthcare professionals to refer out to medical fitness professionals in the community who have experience working with patients with diabetes. So while we had a chance to delve a bit into the weeds and explore much of the data that exists regarding physical activities and diabetes reversal, I want to leave you with 2 straightforward goals for patients wanting to reverse their diabetes to work towards. One is to achieve at least 60 minutes of moderate intensity or 30 minutes of vigorous intensity physical activity daily, and at least 2, preferably 3 full body resistance training sessions per week. This should obviously be in combination with dietary modification and other lifestyle modifications as well. But I think these are good goals for any person to try and work towards. And while those goals are important, the simple take-home message from this presentation is that any physical activity is better than none, and more is generally better. And remember, before you complicate the exercise program too much, brisk walking is one of the most common form of moderate intensity activities and can provide tremendous health benefits and requires almost no resources. So to summarize this module, patients with type 2 diabetes may require additional pre-participation screening prior to initiating physical activity. The newest guidelines recommend at least 150 minutes per week of moderate intensity activity, plus at least 2 sessions of resistance training per week. While the optimal physical activity dose to reverse diabetes is unknown, it is likely that greater than 300 minutes per week of moderate intensity activity, plus at least 3 strength training sessions per week, is necessary. Without question, when it comes to treating and reversing diabetes, diet is of utmost importance. Physical activity should be seen as an important adjunct, along with other lifestyle factors, to effectively treat and reverse diabetes, as there's a paucity of evidence that exercise alone can arrest or reverse type 2 diabetes. And while we started with the provocative quote about exercise remaining the first prescription when treating insulin resistance and diabetes, we will end with a similarly controversial quote, an actual title of a journal article in the British Medical Journal of Sports Medicine. Quote, "It is time to bust the myth of physical inactivity and obesity. You cannot outrun a bad diet." End quote. Would you agree or not? Hopefully this module has given you ample evidence to decide for yourself. Thank you for your time and attention, and congratulations.